Good evening, everyone. I welcome you all for today's webinar on latest updates on cancer treatments 2025. So, with immense pleasure, I would like to invite our first speaker, Dr. Aman Chaudhary, who is consultant medical oncologist, hemato-oncologist, assistant professor, Department of Medical Oncology from Bharatiya Vidyapeeth Medical College, Pune. Sir, the stage is all yours.
Yeah, thanks a lot for the kind introduction. So let me share my slides.
Sure, sir.
Are my slides visible?
Yes, sir. Please make it full screen.
Is it full size now?
Yes, sir. Yes.
Moving?
Yes, sir.
Thanks a lot. So good evening, everyone. Today I'll be speaking on the molecular biomarker testing in lung cancer. So I'll be discussing under following heads: lung cancer in India, biomarker testing in non-small cell lung cancer, evolution of biomarker testing, non-small cell lung cancer, past in the current trends, and the final key takeaways. So the burden of just burden of lung cancer in India as per the Globocan. Just a minute, something. Let me reshare my slides. So the burden of lung cancer in India, as per the Globocan 2020 data, if we see the new cases in both the sexes as per the 2020 data, breast cancer was the most common cancer, accounting for the 13.5% cases, followed by lip oral cavity, followed by cervix uterus, followed by lung cancer, and followed by colorectum. And if we see in males, lip oral cavity was the most common cancer, accounting for 16%, followed by lung cancer, then stomach cancer, then colorectal cancer, then esophageal cancer. So, if we talk about the mortality, breast cancer was the number one killer, followed by lip oral cavity, followed by cervix and uterus. So, 50% of the patient with the advanced non-small cell lung cancer have a driver mutation, which is targetable with a FDA-approved agent or a clinical trial. And if you look at the drugs available, ALK can be targeted by crizotinib, alectinib, ceritinib, lorlatinib, brigatinib. EGFR sensitizing agents are gefitinib, erlotinib, afatinib, osimertinib, dacomitinib. KRAS G12C can be targeted by sotorasib and adagrasib. EGFR exon 20 insertion mutations can be targeted by amivantamab and mobocertinib. MET can be targeted by capmatinib, tepotinib. MET insertion, MET amplification can also be targeted by the capmatinib and tepotinib along with the exon 14 excipient mutation. HER2 can be targeted by trastuzumab deruxtecan, ROS1 by crizotinib and entrectinib, BRAF by dabrafenib. RET by sulfacartinib and prasiltinib, and NTRK by the entrectinib and galcantinib. We can also see the various percentages of the mutations. EGFR constitutes close to around 17%. It's the global data in India. EGFR accounts for the 50 to 60% of the cases. So the importance of biomarker testing in non-small cell lung cancer lies in the fact that studies have shown that patients with identified actionable mutations who receive appropriate target therapy have improved outcomes, as can be seen in the Kaplan-Meier curve. Those who received target therapy had a median OS of close to 19 months, and those who didn't receive had a median OS of close to 11.4 months. and the difference was statistically significant. The guidelines recommend routine biomarker testing to guide treatment decision in advanced non-small cell lung cancer. ASCO says that we should go for EGFR mutation, ALK rearrangements, ROS1 rearrangements, BRAF mutation, MET exon 14 skipping, RET gene fusions, NTRK gene fusions, and PDL1 at the bare minimum. And NCCN also recommends doing KRAS mutations. So the methods which are used for tissue testing in non-small cell lung cancer include DNA sequencing by NGS or PCR. It can detect insertions, point mutations, and deletions. It can also detect aberration in EGFR, KRAS, BRAF, HER2, MET, and a single gene or full NGS panel can be ordered. RNA sequencing panel can detect fusion abnormalities and is more sensitive for ALK, ROS1, RET, NTRK. IHC or FISH can detect ALK, ROS1, and it's highly specialized, can be faster. IHC on the other hand, detects ALK ROS1. It's easy test, fast but not reliable or sensitive enough to guide treatment. It also detects PDL1 expression. So let's see how the biomarkers testing has evolved from the past to the current. So tissue journey for preliminary diagnosis, we need tissue which can be obtained by resection, excision, or small tissue biopsies, which can be then converted to FFP blocks. It can also be obtained by cytology, by fine needle aspiration or exfoliative cytology, via urine ascitic fluid fluid samples. Liquid biopsy, on the other hand, can also provide a sample for doing the mutation analysis. Or then we can go for the morphologic assessment. Then from that we can extract DNA, RNA, or protein, and then we can go ahead with the molecular analysis with the use of PCR, whole genome sequencing, RT-PCRs and proteomics, etc., etc. So biopsy is used to establish diagnosis, is determine histologic subtype and biomarker testing. So histologic subtype can be the squamous or non-squamous. For biomarker testing, primary tumors and metastatic lesions are equally suitable. Bone biopsy can be suboptimal due to decalcification, degradation of DNA. Liquid biopsies, that is the cell-free DNA in plasma, are another option. Tests for EGFR, ALK, ROS1, BRAF, V600E, NTRK, RET, MET exon 14 in all non-squamous non-small cell lung cancer is to be done. It is recommended to use a broad NGS testing to detect most mutations using at least amount of tissue. For squamous non-small cell lung cancer, consider testing in young, never or light smokers, or if biopsy specimen is of mixed histology. Tests for PDL1 expression in all non-small cell lung cancer also recommended. Completion of testing within 10 to 14 working days of biopsy is recommended. Circulating DNA testing has the potential to be applied across all stages of non-small cell lung cancer and throughout the treatment pathway. Diagnosis and treatment selection. Circulating tumor DNA genotyping is recommended for clinical use in advanced non-small cell lung cancer to guide treatment selection under specific circumstances. In resectable non-small cell lung cancer, circulating tumor DNA testing is not part of current clinical recommendation, but may be applied in the setting in the future as biomarker. It can also be used for monitoring prognosis, response to treatment, and progression or relapse of disease. It can also be used. ctDNA testing overcomes some challenges associated with tissue testing, which includes minimally invasive for patients, allowing for serial biopsy if needed. And ctDNA in the bloodstream is comprised of DNA from all tumor sources in the body and captures both tumor heterogeneity and tumor changes over time. So ctDNA may never replace tissue biopsy entirely, but could have a complementary role to support treatment selection in patients with non-small cell lung cancer. ctDNA may be used to detect MRD after surgery in resectable non-small cell lung cancer. In TRACERx study, 24 early-stage non-small cell lung cancer patients were followed longitudinally after section, and ctDNA profiling was done. 93% of the patients with disease recurrence were MRD positive, and 90% of the patients without recurrence were MRD negative. So additional studies to assess ctDNA for monitoring treatment response and relapse in early-stage non-small cell lung cancer are going. In the TRACERx study, ctDNA profiling was able to confirm MRD negativity and detect MRD in patients who relapsed before the disease was picked up by the standard imaging, but we need further studies to use it in the clinical practice. So comparison of tissue versus liquid biopsy testing. There are similarities and differences between tumor tissue and liquid biopsy testing for molecular alteration. Suppose in tumor tissue, sample acquisition requires invasive surgical procedure to obtain tumor tissue. Liquid biopsy, simple blood draw, generally 10 ml is sufficient. If you want to do repeat sampling, then serial testing can be challenging and risky for patients. Liquid biopsy, on the other hand, is minimally invasive and can allow serial testing throughout the course of therapy. Biology correlation with the histology and cell phenotype is possible. Direct correlation between circulating tumor DNA results with histology or cell type is not possible. And lower tumor cell content is acceptable with these sensitive techniques. It is very sensitive, and on the other hand, liquid biopsy is very sensitive method required as ctDNA may comprise less than 0.1% of cell-free DNA. So, if we talk about the evidence of clinical utility, substantial evidence for initial target treatment selection and subsequent treatment after target treatment for advanced muscle cancer. Less but increasing evidence for initial target treatment selection and subsequent treatment after target failure is advanced non-small cell lung cancer. So multiple genes are involved in non-small cell lung cancer. Single gene reflex testing or multiple genes testing by NGS. We can either go for single gene testing, either EGFR, ALK, other gene, or we can also go for multi-gene NGS testing. So what are the advantages of NGS? NGS has a number of advantages over single gene test. As the number of clinically actionable biomarkers has increased, the ability to evaluate all known molecular alteration in a single test has given NGS a major advantage. If one or few molecular markers are needed, higher cost and longer turnaround time versus a single gene. If many molecular markers are needed, reduced cost, shorter turnaround time, and lower tissue requirement versus single gene. Pros of using NGS are detect a broad range of molecular alteration in a single sample, may identify new markers that could offer additional treatment options for a patient and or provide information to help with the development of new and more effective treatment. The cons include high complexity of workflow that requires experienced personnel. Advancement in the field of NGS are evolving rapidly, and patients and the clinical community must receive sufficient education. So techniques and molecular landscape in the non-small cell lung cancer. Single gene assays can detect SNVs, Sanger sequencing, parasequencing, allele specific PCR, single base extension, MLPA, all can detect SNVs. And gene panel assays, amplicon based panels, next NGS can all detect CNVs as well. FISH can detect CNVs, and microarray based CGH can detect SNVs. So EGFR mutation in lung cancer. So sample types used for EGFR testing are FFP section, fresh, frozen, or alcohol fixed specimen can be used for PCR-based assays. Cytology samples are also suitable. Cell blocks are preferred over smears. And discordance between EGFR mutation status in primary tumor and corresponding metastatic sites are rare, so any of the site can be preferred. So EGFR mutation testing in early lung cancer, NCCN recommends EGFR testing in early lung cancer as well. It says consider adding molecular testing for EGFR mutation to be performed on diagnostic biopsy or post-surgical resection sample to ensure the EGFR mutation results are available for adjuvant treatment decision for patients with stage 1B to 3A non-small cell lung cancer. So advantage of NGS over PCR is that one study showed that 48.6% of EGFR exon 90 insertion mutations identified by NGS are missed by PCR. Out of the 17 most common exon 20 insertion mutation variants, only 4 can be identified by PCR. So targeted PCR-based approaches may under-detect EGFR insertion events, and therefore NGS-based strategies are preferred. So if we talk about the ALK rearrangement in non-small cell lung cancer, in most cases, ALK IHC is 93 to 100% sensitive and specific compared to FISH. These are the data from various studies. And false positivity rate of 0.1% can be seen with FISH, although IHC is less expensive. Therefore, it is more widely adopted. ROS1 rearrangement in non-small cell lung cancer. So algorithm for predictive genetic testing for ROS1 in advanced NSCLC is, first of all, testing is done for ROS1 by IHC. If ROS1 is positive by IHC, then it is reconfirmed by a second method, that is a FISH or the molecular assay. Suppose if the ROS1 is positive by FISH, then it is considered positive and considered reconsideration by second method also. Detection of elevated ROS1 protein levels by IHC may provide cost-effective screening prior to confirmatory FISH testing, but it can also only be used for screening, not for confirmation. So if we talk about other mutations, KRAS mutation are mutually exclusive with EGFR and ALK mutation and account for nearly 30% of lung adenocarcinoma. The most common of these arise in the codon 12 and 13, with the G12C variant found in 13% of the patients with adenocarcinoma. predicting poor prognosis versus KRAS wild type. So there is identification of target therapy for patient with KRAS mutation has been hindered by protein structural biology, which has no binding protein pockets large enough for therapeutic agents. Sotorasib is currently approved for patients with NSCLC, and trials for adagrasib have shown potential in early phase 1 to phase 2, 3 trials. So it can be detected by single gene KRAS G12 testing is not currently recommended and should not be preferred as a part of multi-gene panel. Acquired resistance can also occur. So BRAF mutation in NSCLC, BRAF V600E mutation is present in more than 50% of BRAF mutation cases and is thought to be more prevalent in smokers. Non-V600E mutations such as 600K, G466V, and G469A are less prevalent and occur in 17% of patients with a BRAF mutation. Overall, BRAF mutation occur in 1 to 5% of the NSCLC, most commonly adenocarcinoma. BRAF mutations can be targeted by BRAF inhibitors. Addition of MET inhibitor can block one possible resistance pathway and result in improved clinical outcomes. Currently approved therapies for BRAF V600 include dabrafenib plus trametinib, and methods of detection include, IHC and PCR are generally accepted, but NGS is generally used for multi-gene testing panels. So MET receptor tyrosine kinase and the MET exon 14 skipping mutation in non-small cell lung cancer, MET is required in normal embryogenesis and wound healing. 3 to 4% of non-squamous non-small cell lung cancer and 30 to 40% of the sarcoid cancers can harbor it. Majority of MET exon 14 skipping mutations and be detected by DNA NGS, but increased sensitivity with the RNA NGS. So methods for MET exon 14 mutation detection, IHC is not recommended, FISH not recommended, PCR, DNA design dependent, RNA technical considerations are there. So DNA design dependent potentially detects many mutations. RNA is most sensitive. Red tyrosine kinase inter and red fusion in the NSCLC, normal role in the neural genitourinary development. In cancer, red gene rearrangement gave rise to chimeric cytosolic protein with constitutively active red kinase domain. 1 to 2% of the non-squamous non-small cell lung cancer and 20 to 10% of papillary thyroid cancer harbor it. Majority of red fusions can be detected by DNA NGS, but increased sensitivity with the RNA NGS can be obtained. So it can be detected by IHC, FISH, or DNA NGS. RNA NGS, is the preferred. Majority of red fusions can be detected by DNA NGS, but increased sensitivity with the RNA NGS can be achieved. So for NTRK fusions, options include IHC, RNA or DNA NGS, FISH, RT-PCR. Advantages include RNA NGS is the most sensitive, IHC is widely available and fast. Choice of assay will depend on the institution, resources, and the clinical context. Reflexing to NGS versus IHC reasonable for NSCLC due to low prevalence of NTRK fusion. Important to qualify negative results, limitation of sample testing. So IHC is rapid, detect transcribed and translated events only, low cost. FISH is rapid results. NGS is potential for multiplex testing, less depletion of tissue. And disadvantage of IHC include depletion of tissue, fusion partner and position unknown, less validated. Currently, depletion of tissue can also occur with FISH and can be difficult to interpret at times. NGS has a longer wait time for results and cost is high. So choice of assay will depend on institution, resource, and clinical context. Reflexing to NGS versus IHC reasonable for NSCLC due to low prevalence of NTRK fusion. HER2 mutation is detected in 3 to 5% of lung adenocarcinoma, mostly exon 20 in-frame insertions, mostly exclusive with other mutations, mostly seen in never smokers, worse than other subtype in lung cancer mutation consortium. In NSCLC, HER2 mutation and application must be identified using an NGS DNA panel. IHC used to assess HER2 overexpression seen in 59% of the cases and 2 to 3 plus in up to 30% of the cases. This is the 2022 treatment paradigm for molecular biomarkers for non-small cell lung cancer. In EGFR deletion 19 or L858R mutation can be treated by osimertinib, erlotinib, afatinib, gefitinib, and exon 20 insertion by amivantamab, mobocertinib. Uncommon mutation can be treated by afatinib or osimertinib, ALK by alectinib, brigatinib, lorlatinib, siritinib, crizotinib, ROS1, crizo, and triptinib. BRAF, dabrafenib, trametinib, NTRK, and triptinib or lorlatinib. I think we have discussed this in previous slides as well. So PDL expression overexpression, PDL1 can be detected by the DACO22C3, which is a companion test for pembrolizumab, and SP263 for durvalumab, SP142 for antizoli, and 288 for nivolumab. So a different scoring system is adopted depending on the antibody used to detect PD-L1. So biomarkers for immunoheavy in SLC is a controversial topic. PD-L1 sole current biomarker able to guide immunotherapy. Imperfect PD-L1 negative tumors can still respond, albeit mostly when added to chemotherapy, maybe to synergistic effect. TMB, former marker for response, currently not used. Conflicted correlation with this survival in checkmate studies. MSI high MMR not used or relevant in lung cancer. LAT3 possibly related to resistance to immunotherapy being studied. So to conclude, biomarker testing in non-small cell lung cancer has evolved from single gene to multiplex testing. Multidisciplinary meetings help in better understanding of sample and test requirements. Sample should contain adequate tumor content, at least 10%, to prevent delay in processing. Ideal TAT is 2 weeks, that is 10 working days. High throughput platforms such as NGS can be used to screen several genes at a time to provide result within an estimated time. So oncogenic targets and testing methodologies discussed multiple times. This is summarized in the slide. Thanks a lot for patient hearing. If there are any questions, I'll be happy to answer.
Thank you so much, sir, for your talk. So I would like to invite our next speaker, Dr. Shalabh Arora. He is a consultant medical oncologist from Ujala Cygnus Hospital, Haladwani. Sir, the stage is all yours.
I think Dr. Aman will have to stop sharing
Doctor,
his.
I
Yeah.
guess it's
Yeah. Just want to confirm if my screen is
yes, sir.
visible.
Yeah,
Yeah.
yes.
You're right. Right. So very good evening. I think I'll just get on with an overview of lung cancer in general. And so first we'll understand the burden of lung cancer. If you see in as per the Globocan 2020 data, the number of new cases in both sexes combined, there were around 72,000 new cases of lung cancer. It's the fourth most common cancer in both sexes combined. And when you look at males alone, it's the second most common cancer that is encountered. And more so, if you look at the mortality data with lung cancer, out of if you just compare it with the other malignancies in lung cancer, for 72,000 new diagnoses, excuse me, in lung cancer for 72,000 new diagnoses, there were around 66,000 deaths. So what you see that it is a highly fatal malignancy. If you compare it to the malignancies above this, like breast, lip and oral cavity or cervical cancer, you see that the ratio of mortality to total number of new cases is quite high for lung cancer. What we need to know is that there has been a little bit of recent changes in the staging of lung cancer. We have the optimal staging is required for diagnosis at the diagnosis of every new patient. In the AJCC 7th edition versus the 8th edition, the changes that have been seen, first of all, tumors of 5 to 7 centimeters were initially classified as stage 2B, but this has now moved into stage 3A if you have lymph nodal involvement in N1 along with that. And tumors more than 7 centimeter were initially classified as T3, but now they have moved into the T4 category. So there has been an upstaging of this poor prognostic subgroup. And similarly, the N3 category has now gone up to stage 3C. So contralateral, if you have contralateral lymph nodes, mediastinal lymph nodes, then that will upstage the patient to stage 3C. The investigative tools that are required, I'm sure we'll be aware of this, or any patient who is suspected of lung cancer would require to undergo these investigations, bronchoscopy, often to get a sample, or a CT-guided biopsy. You need a CECT or a PET if that's available. For some patients where you have DICE involvement of the mediastinal lymph nodes, you might require a EBUS or an EUS. guided sampling or a mediastinoscopy invasive staging. And if you have suspicious mediastinal lymph nodes, then an MRI brain might be is required in almost all cases of lung cancer to rule out occult brain metastases. So what are the features that on a CT scan which predict for malignancy? If you have lymph nodes with a short axis more than 10 mm, it's a predictor of malignancy. But CT scan alone has a limited role because it has low sensitivity and low specificity. However, if you add on PET to CT, it improves the sensitivity as well as specificity. And I think practically speaking, most of us now, when we encounter a patient of suspected lung cancer, we often resort to a PET CT. What are the factors that would, that would hint that this patient could have occult N2 metastasis at surgery? So these are patients who have central tumors. You can see they have a higher incidence of much higher incidence of N2 disease, 21% versus 2%. Patients with larger tumors, as the tumor size increases, the risk of N2 disease increases, and patients who have had a PET scan with an SUV max of more than 4, these patients have a tendency to have a positive N2 disease subsequently. For mediastinal staging, basically when we encounter patients with stage 2, stage 3 lung cancer, mediastinal staging becomes very important to decide the optimal therapy for these patients. Less invasive method is EUS or EBUS guided biopsy, but often it comes back with an inadequate specimen, so you might require the a little more invasive methods like mediastinoscopy for patients who have suspected mediastinal lymph node involvement. And recommended techniques, like we already saw, if there is clinical suspicion of N2 involvement, if it's high, even after negative EBUS or EUS, then mediastinoscopy is often required. So when do you need this invasive mediastinal staging? If you have a centrally located tumor more than 3 centimeter, we just saw these tumors have a higher incidence of being N2 positive. When there is extensive infiltration of the mediastinum with no evidence of extrathoracic disease, or you have a positive N1, then definitely you need invasive staging. If you have a bulky N2 on CT itself, that's almost always going to be positive, and you don't need an invasive confirmation. When you have a patient with discrete N2, then yes, you do need invasive staging because PET CT might be false positive in some of these cases. And if there is normal mediastinum on CT, but it's positive on PET, again, there's a discrepancy between the two investigations, then you definitely need invasive staging. And if a patient has normal mediastinum on CT and negative on PET, then obviously you don't need to put this patient through invasive staging. So here's a broad guideline. Basically, PET CT with intrathoracic, if you have an intrathoracic lung cancer with or without enlarged lymph nodes, if mediastinal lymph nodes are positive on the PET scan, and you see that they are massive, bulky lymph nodes, then obviously no tissue confirmation is required. You can consider to be positive and straight away go for multimodality treatment. On the other extreme, if you have mediastinal lymph nodes negative on PET, then you look at the clinical probability. If that's low, then you can straight away proceed to surgery or radical radiation. But if you have cases that are in between these two extremes, that is when you will have to resort to invasive mediastinal staging. And the applicability, as we have seen that there are multiple techniques to get to the mediastinal staging. EBUS TBNA or EUS FNA are the least invasive, but they are good only for station 2, station 3P, station 4, and 7 lymph nodes. Whereas if you want to access the other lymph nodes, then you might have to resort to VATS or VAMLA or TEMLA based staging. Right. So what the other thing that we have seen that the evolution of therapy for NSCLC, it was once considered a single disease. And initially it was just said it's lung cancer. Then we looked at it small cell and non-small cell. Then we broke them down histologically, squamous, non-squamous, large cell adenos. And now with the advent of molecular pathology and subsequently PDL1 or TMB, now we know that it is not one disease, it is many diseases that was initially thought to be into one particular type. Now, with the availability of these molecular techniques, and also with earlier diagnosis, the survivals have significantly improved over the past few years for lung cancer. If you see this paper in NEJM 2020, the incidence, the blue lines show incidence, and the red lines show incidence-based mortality. So basically, in men, the incidence has gone down over the past couple of decades. In women, also it has gone down, but not so much. And if you see the mortality has also gone down significantly for both men as well as women, and lung cancer specific survival has improved from 26% previously compared to 35% in those who have been lately diagnosed. And there has been a reduction in incidence along with treatment advances, which is particularly due to the approval and use of these targeted therapies that the outcomes have improved over the past few years. If you see, there's a whole gamut of drugs that have become available over the past few years. There's been a significant increase in both targeted as well as IO therapies. And initially, they were developed for advanced stages, but now more and more they are moving upfront into the first line, into the adjuvant setting, and even in neoadjuvant. So we'll just go through these. So many targets to be identified and so many drugs that are available. So this increases the need for molecular testing, and it is indeed now the standard of care. Whenever you encounter a patient with NSCLC, I think most of us would straight away go and order this panel without as a reflex now, because we know that this data is important for us in order for us to offer the best therapy to our patients. So the current guidelines, stage 1A, everything begins with surgery for early stage lung cancer. For stage 1A, you don't need any neoadjuvant or adjuvant chemotherapy. For stage 1B, 2A, again, not much role for adjuvant chemotherapy except for those with high risk groups, which is typically patients with tumors more than 4 centimeters. For tumors with stage 2B and 3A, 3B, you do need adjuvant chemotherapy. And now in 3A, 3B, also you have data for neoadjuvant chemotherapy. You can downstage these patients with neoadjuvant therapy before you take them up for surgery. So after surgery, the adjuvant treatment would also depend on the factors, whether the surgery has been a complete resection or it's an R1, R2 resection. If it has been complete resection, we have already seen what we need to do. But if it's an R1 or R2 resection for stage 1 or 2A, re-resection is preferred. For patients who do not want to undergo re-resection, you can offer them radiation. For patients in stage 2B, if it's R1, R2 resection, you need a re-resection plus chemotherapy or concurrent chemoradiation. And 3A, 3B, you almost always need a concurrent chemoradiation. But even after this surgery plus or minus chemo RT, you see that more than half of these patients will eventually recur within the next 5 years. And this is a space where we need to improve the outcomes for these patients. The role of adjuvant chemotherapy, we saw that the ESMO guidelines actually recommend that in cases of stage 1B, there was actually a detriment with chemotherapy if you give adjuvant chemo, but in patients who are stage 1B with a tumor size more than 4 centimeter, definitely chemotherapy does improve the survival compared to observation alone. The LACE meta-analysis, often cited, a large meta-analysis of more than 4,000 patients, where patients were pooled and assessed for adjuvant cisplatin-based chemotherapy, and it was shown that adjuvant chemotherapy leads to an improvement in overall survival. Absolute benefit is only around 4 to 5%, and hazard ratio of 0.89. Now, the next question, whether you can give this chemo neoadjuvant for the same subset of patients, stage 1B to 3A. So in the LACE meta-analysis, we saw that hazard ratio for adjuvant chemo was 0.89. Over here, it was shown that hazard ratio is 0.87. So the benefit is almost about the same whether you give these high-risk patients chemo in the adjuvant or the neoadjuvant setting. Now you have targeted therapy that's available in the adjuvant setting for EGFR positive NSCLC that has been completely resected. There was this ADAURA trial. I don't think I need to go into details of this. We all know that it showed very good results. For 3 years, osimertinib was given in the adjuvant setting, and there was a very significant improvement with a hazard ratio of 0.2 in the terms of DFS, and also subsequently overall survival benefit was shown. Now, atezolizumab also showed an improvement in survival in the adjuvant setting for PD-L1 positive tumors, and the survival at DFS at 3 years was improved from 48% to 60%. So these therapies are definitely bringing about a change in what our patients are expecting. A couple of slides on radiation. 2D radiation is now out because now we have advanced technologies where normal tissues can be spared. You see, now with the help of intensity modulated radiation, it has been shown that it improves survival for patients with stage 3 NSCLC, and it reduces the dose that is delivered to the adjacent organs like the heart or the esophagus. And also there is a lower incidence of grade 3 or worse pneumonitis. SBRT versus IMRT. Again, SBRT is a high dose per fraction, 1 to 5 fractions with the 3D localization technique. And SBRT can be given in early stage lung cancer, but since it might cause toxicity at such a hypofractionated dose schedule, it is not often used for large tumors. And the other techniques that are available, image-guided radiation, adaptive radiation. So each of these techniques are actually, bringing the target volume to smaller and smaller areas so that normal tissues are spared specifically. Then there was this trial of increasing the dose of radiation and from 60 gray to 74 gray, and it was shown that plus or minus cetuximab, and they showed that 60 gray is an adequate dosage. Further escalation only led to a detriment in the overall survival, and it doesn't necessarily improve the outcomes. Then came the Pacific trial, which we know was one of the practice-changing trials. They demonstrated that in the Pacific trial that after CTRT for stage 3 unresectable NSCLC, if you give 1 year of adjuvant durvalumab, the overall survival goes up from 33% to around 43%. So 10% of OS benefit at 5 years, definitely a big landmark, and it was practice changing. Then the other emerging treatment paradigms in NSCLC, we have already seen how targeted therapies have helped us, and immunotherapy is also moving up into the front line. What we have learned recently is around half of our patients with non-squamous NSCLC will have a driver mutation, which is either approved or it's on trial. So it's very important that we do screen our patients for these targets, like we have seen in the FLORA trial, PFS with first-line osimertinib versus any first-generation EGFR TKI. The FLORA showed that there was significant improvement in PFS for patients with first-line crizotinib and then later on alectinib. And now even with the ALINA trial, there's data for adjuvant alectinib, which significantly improves the outcomes of these patients. For MET exon 14 alterations or amplifications, you have crizotinib that has shown some activity. For RET arrangements, you have cabozantinib that's available, and now even selpercatinib is available. For NTRK rearrangements, we have drugs available, and for HER2, now TDM1 is also, and later on TDXD has now been approved and is probably going to improve the survival significantly. So if you see the survival historically with the doublet chemotherapies, it used to be around 4 to 6 months. for squamous versus non-squamous, there was this not a very big difference. But now with the advent of these targeted therapies, you can see the survivals are just going up and up with the ALK inhibitors. Here we have only alectinib, brigatinib, and ceritinib. The median survivals have not been reached with alectinib. And now with subsequent therapies getting available with each year, I think it's the benchmark is just going to go higher. Next comes in immunotherapy in NSCLC. CTLA4 inhibitors and PD-L1 inhibitors are available. And ever since 2012, there was the first anti-PD-1 monoclonal antibody was shown to be effective in NSCLC. There has been so many more agents have entered this arena, and the indications are just expanding each year. Now you see with for patients who do not have a target mutation, you have immunotherapy that can be offered to these patients, and this has also significantly improved the survival for these patients. So immunotherapy, if you see for patients who have good PD-L1 expression more than 50%, you can just give them pembrolizumab. And here pembrolizumab has shown that the survival is far superior compared to chemotherapy in these patients. There's almost a doubling of 5-year overall survival from 16% to 32%. Now you have immunotherapy moving on into earlier stages. There are multiple ongoing trials. Some of them results have already come out. You can either give neoadjuvant IO before surgery, or you can do the surgery and then give adjuvant IO. And the results should be available very soon for us to use in the clinic. Then you have you have drugs that are available, antibody drug conjugates like T-DXd that have been approved in breast cancer, and subsequently they are upcoming in NSCLC, which have HER2 positive tumors. CAR T-cell, another exciting area, which was initially started with hematological malignancies, but is now entering into solid malignancies as well. So I think I'll stop with this, and I'll leave you with these messages that management landscape is fast changing in NSCLC. Newer therapies have a huge potential to improve survival, and overall survival has improved across the subtypes. When you have molecular alterations, the survival improves, and also the quality of life is quite good. The ease of oral pills over infusions, as we know, the most of these molecular alterations now have oral drugs available. Patients find it very comfortable, and adverse effects are also being managed adequately. And pulmonologists will play a huge role in early diagnosis, and it's very important to involve them in our NSCLC tumor boards. So I think I'll stop sharing my screen if there are any.
Thank you so much, Dr. Shala, for the insightful talk. So I just had a queries that nowadays, with the advent of so many neoadjuvant immunotherapy approaches, so we feel that probably even now or maybe in the coming 1 or 2 years, the neoadjuvant approaches will be used more frequently to turn into some of the unresectable lesions into resectable ones. So, which exactly are the subset of patient where you feel that are the initially unresectable patient? Have you do you want to share some of the any of your experiences where some of these unresectable cases initially would have gone for CTRT, have been put on neoadjuvant chemotherapy and eventually resected?
Right. So I think I have had very limited experience, to be honest. But yes, definitely, if there are bulky N2 lymph nodes and the surgeon feels it would not be very easy to resect them, then definitely these patients should be given a neoadjuvant chemotherapy, so that you can subsequently make them resectable, and the
Chemo plus
surgeon.
immuno, you mean?
Yes, definitely. Yeah.
Okay. So that may actually change the entire paradigm of how we call which lesions to the entire staging paradigm. Like what do we call resectable, what do we call unresectable, and to staging even the
Yeah.
staging.
Yeah.
Yeah, perfect. Also, thank you so much. If there are any other question from the audience, please feel free to ask. So there are no questions. Thank you so much, Dr. Shalaf. So next, I would like to invite Dr. Nitin SG. Dr. Nitin SG is consultant medical oncology in CK Birla Hospital, Punjabi Bagh, New Delhi. The topic for Dr. Nitin is some case studies where he has seen exceptional responses to osimertinib in EGFR mutated metastatic NSCLC. Over to you, Dr. Nitin.
Yeah, so are my slides visible now?
Not yet.
One minute. Is it visible now?
Sir, it's just showing that you are sharing the screen.
It's loading, I think.
What about
Should
now?
I share from my side?
It's just buffering.
Yeah, please share, please share.
Oh,
Now it's visible. Now it's visible and moving.
Okay. So good evening, everyone. Thank you, Dr. Kapil and the AstraZeneca team for inviting me for this session. So I'll be briefly discussing a few exceptional cases where there was exceptional response to osimertinib with in treatment of metastatic non-small cell lung carcinoma. So from the previous speakers, we had discussion about the importance of molecular testing in the treatment paradigm of lung cancer. Now the lung cancer earlier when it used to be just a blanket chemotherapy, which was the treatment for lung cancer. Now we have moved a long way towards treatment of targeted involvement of targeted therapy in treatment of lung cancer. And one of the most important target that is being seen, especially in our part of the world, is EGFR. And EGFR, we have got multiple generations of tyrosine kinase inhibitors, of which the newest one is osimertinib. And osimertinib was found to have an exceptional responses in most of the cases of lung cancer, especially metastatic lung cancers. As we discussed earlier, initially it was approved for the treatment of metastatic disease, but now it has also moved towards the treatment of early stage lung cancer, locally advanced lung cancer, and adjuvant setting as well. Directly going into the discussion. So first case, the case was diagnosed in October 2020. Mr. X, 64-year-old gentleman, presented with coughing and progressive breathlessness and severe backache. He could not walk without support in the last 10 days, and giddiness since 5 to 6 days, weight loss of 5 kg in last 1 month, and personal history, he was a non-smoker. The PET scan was done and it showed a mass lesion in the right upper lobe. Just you can see in the image that hypermetabolic lesion in the right upper lobe, which is 4.1 into 3.2 centimeters. And along with that, patient also had multiple bony metastasis as well as hilar lymph nodes. So initially, a biopsy was done from the lung mass, and the histopathology was suggestive of adenocarcinoma. And on further molecular analysis, patient was found to be EGFR mutated, exon 19 mutation, and other mutations, targetable mutations were negative. KRAS, BRAF, MET, everything was negative, and PDL1 CPS was also negative. The patient also underwent an MRI brain, which is a basic protocol where all patients with metastatic lung cancer has to undergo a brain MRI as well. And on that imaging, it was found that patient had multiple ring enhancing lesions in cerebellum and cerebral hemisphere with significant perilesional and vasogenic edema. So the final diagnosis was non-small cell lung carcinoma, stage 4, exon 19 deletion, EGFR, with bone and brain metastasis. So initial therapy that was planned was a local radiotherapy for the symptomatic brain metastasis and EGFR TKI to target exon 19 deletion. So coming to the discussion of the treatment of metastatic EGFR mutated non-small cell lung carcinoma, as we discussed earlier, we have 3 generations of tyrosine kinase inhibitors, of which first generation being gefitinib, erlotinib, second generation afatinib, dacomatinib, and the third generation being osimertinib. The FLORA trial was a path-breaking trial which led to the approval of osimertinib in metastatic non-small cell lung carcinoma. As we can see in the cystogram, we can see that in FLORA trial, the median PFS was approximately 18.9 months as compared to other EGFR TKIs, whether it was first generation or second generation, which is hardly around 10 to 15 months of PFS, and osimertinib, it was markedly better. And degree of CNS penetration for osimertinib was also much higher than the other TKIs. At a dose of 25 milligram per kilogram of osimertinib, they had got a brain Cmax of 2.78, and we can see that the last row, which shows the brain versus plasma penetration ratio, and osimertinib had a ratio of 3.41, which is much higher than that of geftinib and afatinib, which is hardly less than 0.5 or maybe 0.21 or 0.36, and it was more than 10 or 12 percentage. The brain penetration with osimertinib was much more than that of first generation or second generation TKI. So this is an imaging which was done, and this is a basic study which shown the CNS penetration and effectiveness of osimertinib in CNS metastasis. Here, all the patients, the patient was given osimertinib, which was tagged with carbon 11, and it was found that, as we can see from the image, those patients who had received osimertinib, subject 1, 2, 3, 4, all these patients had uniform distribution of osimertinib, the carbon 11 being detected by a gamma camera, and we can see that they have uniform distribution throughout the brain. The osimertinib was effectively penetrating into the brain and was distributed within the brain. Regional distribution and binding of carbon 11 osimertinib on PET parametric images shown total volume of distribution. As we can see in day 1, day 2, day 3, 6 hours post single one. Initially, day 1, there was lesser penetration, there was nothing as such. And after day 2, after 6 hours post single dose of osimertinib, 80 milligram, we can see there is hypermetabolic absorption of carbon 11 tagged osimertinib throughout the brain. And by day 22, it has a total volume of distribution, it is distributed throughout the brain, but there is reduction in size of the primary lesion as well. And that is the case with patient 1, and in case with patient 2 also, we can see that pre-dose there was a lesion. The black circle shows the brain lesion or the brain metastasis. By day 2, 6 hour post single dose of 80 milligram dose osimertinib, we can see the carbon tagged osimertinib has distributed through the brain. And by day 22, after 21 days of osimertinib, there was slight reduction in the size of the brain metastatic lesion with uniform extensive distribution of osimertinib through the brain. So managing a patient with EGFR mutated non-small cell lung carcinoma with brain metastasis. So this is the guideline. Newly diagnosed case of EGFR positive non-small cell lung carcinoma, you always do a basic scanning and look for any evidence of brain metastasis. If brain metastasis is symptomatic, then you might have to go for local therapy to reduce the symptoms, especially if the patient is having excessive perilesional edema, midline shift and all. We might have to go for decompressive procedures if it is very severe, or else we can go for SRS or surgical removal to reduce the local symptoms. And if they are not symptomatic, then we can directly go ahead with osimertinib. Now, if we have started on first generation, second generation TKI, if some patient who had primary metastatic disease and were not affording, or the availability of osimertinib was not there when it was earlier, it was not readily available. So if we have started them on first or second generation TKI, and if the brain disease progresses, then if it is symptomatic, again, we'll have to go for local therapy with SRS or surgery. But if it is not symptomatic, we can directly go ahead with osimertinib. So symptomatic disease itself, it could be a CNS progressive disease alone, or it could be CNS progressive disease plus systemic progressive disease also. All progressive disease on first generation, second generation TKI has to be re-evaluated for evidence of any resistance mutation like T790M positive mutation. If T790M mutation is present and there is only CNS PD, we can start the patient off with osimertinib. Well, T790M mutation is negative, then we might have to give a patient a CRS or whole brain RT or SRS, and then we can continue the TKI that has been used previously. While if there is a systemic PD as well as CNS PD and T790M is positive, we can again start off with osimertinib. While T790 negative, then there is no role for adding osimertinib. Instead, we can give, if the patient is symptomatic, SRS or whole brain RT to the brain, and then switch the patient to chemotherapy. So this was a FLORA trial where osimertinib was compared with the first generation TKI, geftinib or Gefitinib or erlotinib, osimertinib demonstrated a superior systemic PFS benefit regardless of CNS disease status at study entry versus the EGFR TK comparator, which was mainly first generation TKIs. So the first Kaplan-Meier curve shows the probability of PFS in osimertinib versus the first generation TKI. As we can see that the curves are markedly separated for PFS, and the hazard ratio was 0.47, which was statistically significant. For osimertinib, the median PFS, probability of PFS, median PFS was 15.2 versus for the first generation TKI, it was 9.6 months. So these were patients who had non or treated CNS mets, while those patients who did not have, without non or treated CNS mets, also had a very good response with osimertinib with PFS of 19.1 months versus 10.9 months with a hazard ratio of 0.46, which was statistically significant. So in FLORA trial and the brain outcomes, we can see that in the osimertinib chart, where FLORA we compared with the first generation TK, the baseline asymptomatic CNS mets were almost 116 patients. 116 patients had baseline asymptomatic CNS metastasis, while 128 patients have baseline asymptomatic CNS metastasis determined by neurological BICR. And the response, both the patients had systemic response, while baseline asymptomatic CNS metastasis determined by neurological evaluation, they had CNS response as well. The response rate was 66% for of the CNS disease response was 66% with osimertinib versus 43% for first generation TKI. And the median CNS PFS was 15.2 months versus 9.6 months by investigator assessment for patients who had baseline asymptomatic CNS metastasis, and those patients whose symptomatic CNS mets, those patients who had metastasis which has been determined by neurological evaluation, they had a significant improvement in CNS PFS, which was not reached during the trial period versus 13.9 in patients who had first generation TKI. So this patient, he was diagnosed in October 2020, and November 2020 for bone metastasis, we gave palliative radiotherapy to spine for backache with bone modifying agents. And for brain metastasis, patient was not willing for brain radiotherapy and wanted to just start on just TKI. And patient was started on osimertinib 80 milligram per day as first line therapy. Follow PET scan was done in March 2021. As we can see in the image, right upper lobe lung lesion encasing the right upper lobe bronchus. There was marked reduction in size of the primary lung lesion. Initially, it was 4.1 into 3.2 into 3.4 centimeters, and it reduced to 2.2 to 2.1 centimeters. The hilar and paratracheal lymph nodes also decreased in size. So effectiveness of TKI in brain metastasis, efficacy of osimertinib and first generation EGFR TKI, as we discussed earlier. So the in FLORA trial, it was seen that CNS objective response rate was 66% for osimertinib, while it was 43% for erlotinib or gefitinib, and the CNS DCR was 90% for osimertinib, while 84% for erlotinib or gefitinib. And median CNS duration of response was not reached in those patients who had asymptomatic brain mets. It was not it was not reached versus 14.4 months in erlotinib or gefitinib. So follow-up MRI scan was done in February 2021, and as we can see, there was almost a complete response with almost complete disappearance of all the brain space-occupying lesions within the brain. In July 2021, there was complete resolution of brain lesions on MRI brain, and no additional intervention was needed. So these are case reports on osimertinib and brain metastasis in non-small cell lung carcinoma. Another one were 53-year-old patient who had relapsed lung cancer while being on chemotherapy for stage 3A lung cancer. Subsequent scans revealed pretracheal nodal hypermetabolism. On repeat brain MRI, she was found to have multiple brain metastasis, including 3.1 centimeter metastatic lesion in the inferior vermis. Patient was started on osimertinib 80 milligram daily, and patient complained of ataxia, which worsened initially significantly in the following days, and was scheduled for craniotomy and tumor resection in the following week. So these are the scans which has been done in the subsequent days. The baseline scan has shown a large lesion at the inferior vermis, as we can see in the image, when just before the osimertinib was started, and at by day 15 there was marked reduction in the size of the lesion, which is obvious in the scans, decrease in size of lesion, and there was marked resolution of symptoms. Initially the patient had ataxia and we were planning for craniotomy or tumor resection, but within 15 days patient had marked improvement in their neurological symptoms, and there was reduction in size of the tumor on the subsequent scan. And by day 60, there was complete resolution of lesion in the brain, and the patient had complete resolution of the symptoms as well. So the complete remission of multiple brain metastases in a patient with EGFR mutated non-small cell lung carcinoma treated with first-line osimertinib without radiotherapy. This is another case study where phase 2, phase 3, multiple phase 3 trials have also been done in these scenarios. So this is another case where 74-year-old woman who were diagnosed with T4N1 M1C stage 4B lung adenocarcinoma with EGFR mutation presented with a left upper lobe mass and multiple bilateral lung mets, a total of around 20 asymptomatic brain metastases with a maximum diameter of 12 millimeter were diagnosed simultaneously. So patient was initially started on osimertinib itself. Whole brain radiotherapy was planned but was deferred because patient had no neurological symptoms. And after 5 weeks, multiple brain metastases disappeared completely together with response to the lung lesion. So this was another case report which suggested that we can actually defer radiotherapy unless a patient is symptomatic. There is a marked neurological symptoms because of edema or tumor compression. Unless a patient is having these symptoms, we can actually go ahead with just TKI because with market CNS penetration of osimertinib, the response is very good, and hence the radiotherapy could be deferred, and hence we can actually prevent radiotherapy related toxicities that can develop later. So another study which demonstrated efficacy in CNS metastasis. This was published in Neuro-Oncology paper, and here in this was a non-randomized phase 2 open label 3-arm prospective study. Here the patients were either treatment naive and has been started on osimertinib or previously treated with EGFR TKI, and then patient was T790M positive and was started on osimertinib. So these patients have been followed up with after starting osimertinib, and those patients who had isolated intracranial progression, osimertinib was escalated from 80 mg once daily to 80 mg twice daily, a total of 160 milligram dose. So it was found that in those patients who are treatment naive, the objective response rate was 84.2%. Those patients who have progressed on first line TKI and has T790M mutation positive and was started on osimertinib as second line, they had an objective response rate of around 66%. And those patients who have even T790 negative, they also had good response with 50% objective response rate. And all these patients had and this median PFS for these patients for arm A it was 11.8 months for those patients who are treatment naive, 7.6 months for those patients who had T790M mutation and osimertinib started in second line, and 6.3 months for those patients who was T790 negative. So osimertinib demonstrated high efficacy on brain metastasis, and all trial arms, whether it was T790M positive or negative, or those patients who have started on first line or second line, all trial arms displayed a significant decrease in the number and diameter of target lesions over the period of study, over the study period. So further, coming back to our case, which we have been discussing, on further follow-up PET scan in November 2021 and November 2022, both repeat scans showed a complete response of the primary lesion within the lung as well. As we discussed earlier, the patient had a response within the brain with complete resolution of all the CNS lesions, and in subsequent scans also showed complete resolution of the primary lesion as well. So the key points and food for thought: radiotherapy for brain is not needed for all cases, and earlier it used to be the standard of care for all patients who had brain metastasis. But with the advent of third generation TKIs, especially osimertinib with high CNS penetration, we can defer radiotherapy and thus save the patients from the late adverse events of CNS radiotherapy. Almost complete resolution of primary disease and nodes are even seen with this with the initiation of osimertinib. None of the patient had any severe adverse events. Patient remains progression free even after 19 months after initiating osimertinib, and the patient was the current patient which we were discussing was asymptomatic, fully active, and goes for morning walks and yoga sessions and is leading a normal life. So excellent response to osimertinib. Are such tumors different? No, most of the tumors who have got EGFR exon 19 class deletion or exon 21 mutation usually have a very good response to osimertinib. And do we have any biomarker to predict such excellent response? We don't have as such any other biomarker, but EGFR mutation itself is a good predictor of response for third generation TKIs. Thank you. I'll be happy to take any questions.
Thank you so much, Dr. Nitin, for the insightful talk. So I just wanted to understand from you that suppose if a patient of NSCLC with brain metastasis comes to you, EGFR mutated metastatic brain metastasis and brain metastasis related it's symptomatic. So as you have also mentioned in your presentation that many patients had marvelous CNS response. So do you feel comfortable in letting the patient be on osimertinib alone, or you still want to treat them with some kind of radiation before starting osimertinib?
If patient is totally asymptomatic, then I would definitely go with osimertinib alone. Now the question comes whether the chemotherapy has to be added or not. For CNS point of view, I don't add chemotherapy, but otherwise, if it is a bulky disease, patient is young and fit, then I start chemotherapy. But radiotherapy part, definitely I defer until the patient is symptomatic, and usually look for a follow-up scan. If the scan is not responding well or a single lesion is there which has not responded well, then I might go for SRS. Upfront, patient asymptomatic, always single agent osimertinib.
Okay, great. Thank you. Okay, so if there are any other question with Dr. Nitin? Okay, thank you so much, Dr. Nitin, for the talk. Next talk is
Thank you.
will be taken by me, the reimaging in CNS mutation, EGFR mutated advanced lung cancer, and how treatments compare. Next slide, please. So first, to give a brief overview of NSCLC, first we'll talk about the incidence. Next slide. So as we know that out of all NSCLC, 80 to 85% cases are non-small cell lung cancer and only 10 to 15% are small cell lung cancer. Now that we are doing the molecular profiling for each patient, it has turned out that many of these patients have EGFR mutation. It is 70% globally, but if you look at the India specific, particularly in the non-smoker patient, it may reach up to 35 to 40%. Second actionable one, second most common is the ALK, HER2, MET, NTRK. All these mutations are also there. KRAS is one of the most common, which is present in almost 29% of the patient. However, for most of them, it is not actionable, and approximately 32 to 35% patients do not have any identifiable target mutation. Next slide, please. So NSCLC, as already told, it accounts for 80 to 85% of all lung cancer cases, and EGFR is the commonest actionable mutation observed. Next slide. If you look at the incidence of EGFR mutation across the world, it is highest in the Asia, 36 to 40%. Same is seen in India as well. While in Russia, it is 18%. It is the least in the Middle East, only 8.5, almost 10% of the patient have. In Australia, 25%. In South Africa, it is 22%. If we talk about Europe, it is approximately 15%, well, slightly higher in Americas, that 25%. Next slide. There is significant geographical variations. Patients with lung cancer have the highest rates of identified brain metastasis, and such incidences are more pronounced in EGFR mutated patients. So in the figure, you can see anatomy of brain, which is leptomeningeal metastasis seen commonly, then dura matrix, subdural space, arachnoid space, and subarachnoid spaces are there. It is seen that 44% of the patient with EGFR mutated tumor had brain metastasis compared to only 22% of the patient with wild type EGFR. Leptomeningeal metastases have poor prognosis. They're not treated with the average survival of only 4 to 6 weeks. Leptomeningeal metastasis may be more frequent in patients with EGFR mutated NSCLC compared to wild type EGFR, which is 9.4% compared to only 1.7%. So as to say, you can say that EGFR mutated we have more propensity compared to EGFR wild type NSCLC for brain metastasis. Next slide. Approximately 10 to 20% of NSCLC patients have brain metastasis at the time of diagnosis, and approximately 40% will develop brain metastasis during the course of disease. Next slide. Here we have the site of metastasis, which affects quality of life. So different metastasis site have deterioration of quality of life. It is shown that if patient has adrenal gland, the quality of life deteriorates only to 83 points, 0.83 score, while in the brain it is 0.52. So and same in the bone. With liver and contralateral lung, it is 0.71 to 0.69. So decline in quality of life is the greatest when patient has brain metastasis, and compared to other site of metastasis. Next slide, please. Now we'll talk about how brain metastasis in EGFR mutated advanced NSCLC responds to TKI. Next slide. We already know that brain is a sanctuary site for invading metastatic tumor cells as it is protected by the blood-brain barrier. Up to 40% of the patient with NSCLC with EGFR mutation will develop brain metastasis at some point of time. EGFR TKIs are also substrates for human blood-brain barrier efflux transporters to varying degrees, and this influences the distribution of compound in the brain at equilibrium. Hence, it is imperative that EGFR TKI must have good brain exposure if they are to achieve intracranial efficacy. Next slide. We know that osimertinib differentially penetrates the intact blood-brain barrier in monkey brains in preclinical studies. Here we have seen the SPECT images of monkey brain, the different molecules like osimertinib, AZ15104, olmutinib, rosilectinib, EGF816, ASP8273, erlotinib, and geftinib are shown. Higher the radioactivity in brain, which is denoted by green and yellow and red lights, higher is the blood-brain penetration. If you look at the osimertinib arm, so it has the maximum brain penetration followed by AZ5104. Geftinib, but none of these have any kind of brain penetration. Somewhat is there in the AZ5104. However, osimertinib has very good brain penetration. Next slide. Also, in preclinical studies, osimertinib demonstrated higher mouse brain concentration than other TKIs. Here, the 4 drug comparison is given: the osimertinib, geftinib, rosilectinib, and afatinib. The doses were given as per standard. The brain Cmax was achieved maximum in the osimertinib. The studies on animals show that osimertinib has highest brain penetration of EGFR TKI study. If you look at the curve on the right side, with the passing time, only the blue line denoted by osimertinib showed some radioactivity in the brain. Next slide. Whole brain radioactivity. Osimertinib causes tumor regression in EGFR mutated brain metastasis in a mouse xenograft model, that is PC9. What happened in mouse models, intracarotid artery injection of tumor cell were done so that the brain metastasis was artificially created. In mouse brain, tumor formation happened, and confirmation of tumor formation target expression were done by the means of histopathological examination and IHC. Then mouse PC9 tumor growth inhibition with osimertinib was seen by CO1686 and control. Osimertinib is denoted by pink line. When it is solid, it is 5 mg per kg per day, and when it is hollow, it is 25 mg per kg per day. So you can see that osimertinib demonstrated good activity compared to CO cobalt 1686. Next slide, please. Osimertinib was homogeneously distributed in all regions of brain in healthy volunteers. So these are the healthy volunteer, human volunteer brain. 8 subjects received osimertinib. If you see in all of them, in all of the subjects, the distribution was sort of homogeneous. It was more in subject 1, 7, and 8, lesser in subject 2 and subject 3, but it was homogeneous. Next slide, please. Also, osimertinib achieves brain exposure in patients with EGFR mutated advanced NSCLC with brain metastasis. There is shown the regional distribution and binding of radio-labeled osimertinib on PET parametric images showing total volume of distribution. So patient 1 and patient 2 both are shown on PET scan day 1, day 2, and PET scan 1, PET scan 2, and PET 3. These PET scans were taken at the baseline 6 hours post single osimertinib dose and on day 22. In the second patient also similar timeline was followed. If you can see from PET 1 to PET 2 to PET 3, within 3 weeks, optimal brain penetration was achieved in both the patients. Next slide. So osimertinib binds irreversibly to clinically relevant mutant EGFR kinase forms like L858R, exon 90 deletion, and T790M to selectively inhibit mutant EGFR kinase activity. Prolonged PFS and OS relative to first generation EGFR TKIs. It exhibited anti-tumor effect in patients with NSCLC harboring various EGFR mutation, common or uncommon. High blood-brain barrier penetrance and brain exposure relative to other EGFR TKI is active against CNS metastasis. inhibited growth of CNS metastasis in patient with EGFR mutation positive NSCLC. Next slide, please. So, having understood the preclinical studies and background, now we need to know how does the efficacy of osimertinib compare to first generation TK in the treatment of NSCLC with EGFR mutation. Next slide, please. Here we have FLORA trial, which is EGFR positive metastatic NSCLC who are treatment naive. Osimertinib was given in the first line. After screening, 994 patients with EGFR mutation positive advanced NSCLC were taken. They were randomized in 2 arms. Osimertinib 80 mg per day, that was the experimental arm, and the control arm was your comparator EGFR TK, that is erlotinib 150 mg per day or geftinib 250 mg per day. Eligible patient randomized stratified by tumor EGFR mutation, exon 19 deletion or L858R, and race Asian or non-Asian. Primary endpoint, it was assessed in June 2017 after 342 PFS events. Final analysis were done in June 2019 after 321 deaths. Primary endpoints were progression-free survival as well as overall survival. Majority of the patient had metastatic disease, while 35% had visceral metastasis and 21% had CNS metastasis. Next slide, please. If we look at the FLORA results, number of patients were 279 in the osimertinib arm and a comparator arm had 277 patients. Median PFS was marvelously improved from 10.2 months in the comparator arm to 18.9 months in the osimertinib arm with a hazard ratio of 0.46. Median overall survival was also improved from 31.8 months to 38.6 months with the osimertinib. So PFS, we know, is a direct measure of drug benefit in patient with known or treated CNS metastasis. Median PFS of 15.2 months with the osimertinib arm compared to only 9.6 months in the comparator EGFR TKI arm. Hazard ratio was 0.47. If we talk about OS, then osimertinib had significantly longer OS than comparator EGFR TKI at 24 months, 74% versus 59%. At 36 months, it was 54% versus 44%. If you look at ORR, it was also higher in the osimertinib arm, which is 80% compared to 76% with compared to EGFR TKI. If you look at the CNS metastatic patient, metastatic CNS PFS was not reached with osimertinib compared to 13.9 months with the comparator EGFR TKI. Also, the CNS ORR was 66% with osimertinib compared to only 43% with the comparator arm. Next slide, please. If you look at the detailed analysis of CNS effects, patient who had known CNS metastasis or who had been treated with CNS metastasis, the osimertinib had superior PFS of 15.2 months compared to 9.6 months with standard of care with a hazard ratio of 0.47. However, if you look at patient who did not have any CNS metastasis, naturally osimertinib showed good response of 19.1 months PFS compared to 10.9 months. Here hazard ratio was 0.46. So irrespective of baseline metastasis or not, efficacy of CNS, efficacy of osimertinib was maintained compared to other EGFR TKIs. CNS progression events occurred in 17 versus 42 patients receiving osimertinib versus standard of care. So in FLORA trial, osimertinib demonstrated a superior systemic PFS benefit regardless of CNS disease status at study entry versus EGFR TKI comparator. Next slide, please. If you look at the FLORA results, the same CNS full analysis set I've already discussed. Next slide, please. If you look at the intracranial PFS, the median CNS PFS was not reached in the osimertinib arm compared to 13.9 months with the standard of care arm. Hazard ratio was 0.48. CNS PFS was statistically significantly better with osimertinib compared to comparator standard of care. Next slide, please. CNS progression by BICR occurred in 20% of the patient in the osimertinib arm compared to 39% in the EGFR TKI arm. Not only treat but also prevents the CNS metastasis. Next slide, please. If you look at progression in CNS only, that was also much less in the osimertinib arm. In FAS, which included patient with and without CNS metastatic trial entry, investigator assessed CNS progression events which were observed in 6% patient in osimertinib arm compared to 16% in the EGFR TKI arm. Next slide. If you look at number of patients who continue to receive first-line trial drug, osimertinib, at the end of 3 years, 28% patients were still on osimertinib compared to only 9% who were on EGFR TKI comparator. Next slide. So first-line osimertinib may delay the need for subsequent therapies. 28% versus 9% patient continue to receive the first-line trial drug after 36 months. Next slide. Now we look at some real-world evidence of osimertinib with CNS metastasis. Next slide. Here we have two case report which showed rapid intracranial response to osimertinib without radiation in non-small cell lung cancer patient harboring the EGFR T790M mutation. Next slide. Case 1. A 67-year-old woman without a history of smoking who had Behçet disease underwent right middle lobe resection of lung because of an early stage of NSCLC 9 years ago. Multiple nodules emerged in both lungs on computed tomography images 7 years ago, which was recognized as recurrence. EGFR mutation analysis identified EGFR L858R mutation. Gefitinib was administered as first-line chemotherapy for 2 years and 11 months after 3 lines of cytotoxic drug regime of carbopem, Tegafur, Gemarasil, bevacizumab, docetaxel. Erlotinib was administered at 5th-line chemotherapy, which failed in 3.5 months. After 2 courses of vinorelbine administration at 6th-line chemotherapy, the patient complained of unbearable back pain. Spinal MRI examination detected multiple thoracolumbar bony metastasis. As 7th-line chemotherapy, osimertinib 80 mg per day was administered. From the next day, the brain nodules were detected. On the day 5 after administration of osimertinib was started, a chest X-ray revealed shrinkage of right pulmonary nodule. CT images on day 13 revealed complete remission of brain metastasis except for one lesion in the left frontal lobe. Next slide. So patient underwent right middle lobe resection of lung because of an early stage of NSCLC 9 years ago. Multiple nodules emerged in both lungs on CT 7 years ago, which was recognized as recurrence. Identified the EGFR L858R mutation in exon 21. Gefitinib was administered as first-line chemotherapy for 2 years and 11 months. After 3 lines of cytotoxic drug regime, erlotinib was administered at 5th-line chemotherapy, which failed in 3.5 months. After 2 courses of vinorelbine administration at 6th-line chemotherapy, the patient complains of back pain with MRI examination detecting multiple thoracolumbar bony metastasis. Radiotherapy was conducted to control pain and prevent fractures. Bronchoscopy had been conducted as rebiopsy, detecting an additional mutation that is T790M in exon 20. At 7th-line therapy, osimertinib was administered from the next day. The brain nodules were detected when ECOG performance test was 3. Next slide. Here you can compare both the CT scan pre-treatment and day 13. Within 13 days, multiple metastasis at the baseline, complete remission of brain metastasis except for one in the left frontal lobe after 13 days of osimertinib treatment. Shrinkage of right pulmonary nodule after 5 days of osimertinib administration. Next slide, please. This is the second line, the second case. Next slide. A 76-year-old man with a history of 22.5 pack year smoking underwent right upper lobe resection of lung because of an early stage NSCLC 10 years back. EGFR exon 19 deletion was detected. Multiple bony metastasis as recurrence emerged 6.5 years ago. Gefitinib was administered as first-line therapy for 4.5 years. Afatinib was administered for 10 months after sandwiching 4 courses of PEM-carbo with BEV, while 4th-line chemotherapy, Tegafur, Gemarasil, Udarasil was being administered. Pleural effusion with right side dominance was seen. A thoracocentesis was conducted and detected the additional mutations T790M in exon 20. Osimertinib was administered at 5th-line therapy when the ECOG performance status grade was 2. Next slide. On day 10 after administration of osimertinib was started, the CT images revealed the remission of single brain metastasis in the right parietal lobe, which was asymptomatic. On day 14, decrease of pleural effusion and shrinkage of pulmonary nodule were recognized apparently on chest X-ray. After a month, chest CT images revealed shrinkage of multiple drug metastases and decrease of left-sided pleural effusion. His performance status gradually improved to 1 and decrease of pleural effusion happened. Next slide. Here you can see the CT scan and pre-treatment and data and complete remission of single brain metastasis after 10 days of osimertinib treatment. Next slide. After 14 days, decrease in the pleural effusion, shrinkage of pulmonary nodule. After 31 days, shrinkage of multiple lung metastases and decrease in the left-sided pleural effusion. Next slide. Third case report from Japan. Complete remission of multiple brain metastasis in patient with EGFR mutated NSCLC treated with first-line osimertinib without radiation therapy. Next slide. It is a 74-year-old woman with a no history of smoking, elevated blood CEA level. The CT scan revealed a 40 shadow in upper lobe of the left lung and multiple bilateral small nodule in the entire lung field. Diagnosed with T4N1 M1C stage 4B lung adenocarcinoma with EGFR exon 90 deletion mutation. More than 20 multiple asymptomatic brain mets with a maximum diameter of 12 were detected on MRI. Osimertinib 80 mg once a day was administered as first-line treatment. Whole brain RT was deferred. Next slide. If you look at the CT scan, 40 white shadow in the upper lobe of left lung is seen and multiple bilateral small nodule entire lung fields are also seen. Next slide. In brain MRI, multiple asymptomatic brain mets are seen with maximum diameter of 12 After 5 weeks, the multiple brain metastases has disappeared completely. Next slide. Now, this is a cohort study which showed intracranial outcomes of de novo brain mets treated with osimertinib alone in patients with newly diagnosed EGFR mutant NSCLC. Next slide. It was a retrospective cohort study. Patients were selected from an institutional database if they had a diagnosis of EGFR mutant NSCLC and treated with osimertinib between 2014 and 2022. They received osimertinib alone as initial therapy after first brain metastasis diagnosis, had at least one intact brain mets not previously treated with systemic or local therapy like stereotactic radiosurgery, whole brain radiation or surgery at osimertinib initiation, and who had baseline brain MRI before and at least one scan after osimertinib initiation. Next slide. Here are the different MRI scans. If you look at the baseline, there were many ring enhancing lesions are seen which are metastasis. 2 months post osimertinib, many of them have decreased in size. 34 months post osimertinib, patient is still in remission. Disease control is seen after 3 years of therapy. Next slide. So there were 36 patients who had a median interval from brain metastasis diagnosis to first-line osimertinib initiation 25 days. 136 previously untreated brain mets were tracked from baseline. Overall, 105 lesions had a complete response and 31 had partial response from baseline MRI. This reflects the best overall of 100%. 2-year overall survival was 80%. CNS progression rates at 1, 2, and 3-year post osimertinib was 21%, 32%, and 41% respectively. Lesion level local failure was estimated to be 0.7% and 4.7% at 1 and 2-year post osimertinib respectively. Next slide. So what are the recent guideline updates suggest? Here we have the NCCN guideline, which are 2023. Next slide. Here, osimertinib has been selected as category 1 in patients who have EGFR mutation and NSCLC. Next slide. Thank you for the patient listening. If there are any questions, I'll be happy to answer. Since there are no questions, Thank you so much, organizers, for arranging this symposium. So I'm sure that all of us have learned a lot in the recent management guidelines of EGFR mutated lung cancer. Such kind of discussions are important to make us oncologists aware about the recent advances so that we can deliver the best care for our patient. Thank you so much, everyone. Thank you all the attendees for
Thank you
listening.
so much, sir.
Thank you all the
Thank you
speakers.
so much, sir. Thank you.
Thank you all the speaker for the wonderful presentation. Good night, everyone.
Right now.
Thank you. Good night.
Good night.